You solemnly swear the testimony you're about to give in this action will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Thank you. You may be seated.
Thank you. Hello.
Please state your complete name, spelling both your first and last name for the record.
Stephen with a V, Arthur Holper, Holper.
Need you to spell your first name.
Stephen with a V, Steven.
Thank you.
Go ahead.
Thank you, Your Honor.
Good afternoon, Dr. Holper.
Afternoon.
Did I retain you to review some records relating to Mr. Copenhagen?
Yes.
Okay. I want to start by going over your training experience and your education. Can you please talk to me about your initial education?
I graduated from the University of Illinois, Circle Campus in Chicago. Then I went into chiropractic college. I graduated as a chiropractic physician, practiced for about 1.5 years in the Chicago area, and then I decided to go into medical school. So I went down to Guadalajara, Mexico, and I applied, and I got into it's about a 5-year program. After 3 years, I was able to transfer back up to the States. I finished my program through the Chicago Medical School. I entered into a rehabilitation medicine program through the Chicago Medical School. I graduated the program and then went to private practice in Chicago. So I graduated University of Illinois with a bachelor's in biology, the chiropractic college with of course, a doctorate in chiropractic and also a bachelor's in human biology, and of course, medical school with my MD. So my primary focus is rehabilitation medicine, pain management. I also do addiction medicine. And I have a background in, of course, addiction medicine and head injury, spinal cord injury, which is what we do in our residency program in rehab medicine.
And since, what year did you graduate medical school? Not to embarrass you, but...
No, it was a long time ago. It was well, don't forget I went to chiropractic college. But I think I graduated medical school in about 82, I think, or 83. And then I graduated my residency program, I think about 86, 87, something like that.
Okay. And since then, have you completed continual updates and trainings in the medical field?
Yes.
And can you just describe the nature of those, like how many hours a year or every other year? Or...
So to maintain our license active, we have to go through so many postgraduate hours, and I usually get about 3 or 4 times what I'm supposed to get because I like to keep up in as many areas of medicine as I can, primarily referencing pain management and addiction medicine. So I usually attend maybe 4 or 5 major national courses per year, and then some local seminars. So I try to keep myself well-rounded and up-to-date.
And are you a member of any boards or organizations?
Yes, American Academy of Pain Management and American Society of Addiction Medicine. There's some others. I don't keep track of all of them.
Okay, I saw on your CV there are quite a few.
Yes.
All right, and are you experienced in diagnosing, treating, and rehabilitating brain injuries?
Yes.
And are you familiar with something known as a traumatic brain injury?
Yes.
Can you please describe for the jury what that is?
Well, first off, there are many different ways that in medical literature and in the lay literature that we describe head injury or brain injury, however you want to put it. And basically it's simply damage to the brain that is more than just you hit the head and then everything's fine, have a bit of a headache and everything's fine after that. It's where their symptoms basically linger. And if they linger, these symptoms linger beyond, say, 3 months or so, then we consider them to be rather significant. And then we can define that as a traumatic brain injury, post-concussive syndrome, however you want to put it. The literature I'm sure you've heard about the high school athletes and the professional athletes getting hit in the head, and they have this a program. They're trained. Trainers are trained to observe for certain neurologic abnormalities or signs or symptoms that have to do with head injury. So it's a big issue these days. But in any case, in rehabilitation medicine, which is my specialty, our primary focus is spinal cord and head injury, strokes, things like that. Now I kind of lost track of your question. I think I hope I answered it.
I was asking you to explain what traumatic brain injuries were.
So what happens is they've done studies on some poor little animals, and they subject them to head injury, and then they take them apart and dissect them out. They look to see what their brains look like under the microscope, and they study the behavior after head injuries, and then they try to extrapolate. Of course, you can't take a human being and hit him over the head or dissect him, so you have to try to come as close as you can to emulating a human's head trauma. So you study the effects on animals, how they behave and that, and then try to figure out, try to extrapolate to see how that would affect a human being. And of course, we also study humans that have had strokes, traumatic brain injury, things like that. We document how they respond. We do MRIs, and with an MRI, we can see where the lesions are. And then we see how they behave, so that we can connect a lesion on the MRI to how they behave. And we can say, well, a lesion in this part of the brain causes this set of symptoms. The traumatic brain injury, simply whereby patients after an injury can exhibit a myriad of symptoms: nausea, vomiting, blurring of vision, memory issues, coordination issues. And then there's a degree. Some are minimal, some are extensive, so it depends. If you define TBI, then you have to define to what extent you have that type of injury. In other words, the effects, how significant they are. So you define it, number one, as TBI after 3 months, and then afterward, how you manifest from a symptomatic perspective.
Okay. And with respect to that, are there many different names for what they're calling today concussion syndrome or CTE, chronic traumatic encephalopathy?
Right, post-traumatic encephalopathy, various ways. There's closed head injury, traumatic brain injury, then there's post-concussive syndrome, concussion, many different ways to define it, to label it, I should say.
And is the way you choose to label it is traumatic brain injury?
Yes.
And if I refer to that as TBI, that would be the common abbreviation?
Yes.
All right. Before we get into the MRI, is one of the important things that you do in putting together a treatment plan or putting together a full diagnosis for a patient, going over medical and social history?
Could you rephrase that question? I'm not sure I understand.
Well, let me just jump into it. Did you order MRIs for Mr. Copenhagen in this case?
I did.
Were they something known as a contrast and a non-contrast MRI?
That's one way you can order it, yes. So we order some contrast, some non-contrast. It depends on how long after the injury, how long it was after the injury. But there are various ways to do it. You do CT, but MRI with, without contrast, depending.
What did you order?
I'm sorry, go ahead.
What did you order in this case?
I ordered a MRI with, without contrast,
Thank you.
as I recall. Sorry.
No, that's fine. And did you receive results, Wednesday? Did you receive results for that on Monday?
I believe so, yes.
All right. And did you have an opportunity to review those results?
Yes, I did.
And do you have those results with you, or are you just familiar with them?
I'm familiar.
All right. Can you talk generally about the technique, what a contrast, non-contrast MRI are?
One is simply you go into this machine, it takes an MRI, a picture of your brain, and the other one is where you take a non-contrast study and then follow that with a contrast study, whereby you inject a material into the vein, which then lights up where there's certain areas of concern, lights it up for you on the MRI scan.
Okay. I wanted to go back to one thing. You talked about something called a lesion on the brain. What is that?
A lesion is an area of abnormality.
And you said MRI, and you go into a machine. Can you just describe that a little bit more?
Yeah, MRI is like a CAT scan. You go to this little tunnel and put earphones on because it's a rather loud machine. And the MRI takes slices of the area under study, and it puts it all together into a picture that we can appreciate. It's almost like taking the brain, or in this case the brain apart, and sectioning it and looking at it under a microscope. That's what or looking at it. If you can take it out and look at it, that's what the MRI does for you.
Okay. Now, in terms of the findings from Mr. Copenhaver's MRI, I believe you already said you found some significant?
I found some abnormalities, yes.
Okay. And was one of the abnormalities focal abnormal signal intensity
Yes.
involving frontal superior subcortical white matter consistent with shearing, diffuse axonal injury, and the history of head trauma, clinical...
Counsel,
Yes.
are you going to read from the report?
No, I'm asking if that was one of the findings.
I think it'd be, first off, I didn't interpret it, the radiologist interpreted it. I reviewed the studies, and I believe what you were trying to suggest is the report referenced axonal shearing, which is where on the MRI you can actually see where the axons, those are the fibers that conduct impulses from one part of the brain to the other. The axon is sheared. We can see it on the MRI whereby there's trauma, there's swelling around the various axons, and we can, by that abnormality, we can determine that there's been damage to the axons. The axons are, again, there's billions of them in the brain, and they conduct signals from one area of the brain to the other.
Okay. In sort of layman's term, what does that mean?
It's like a telephone wire. You cut it open, there's like millions of different wires inside the one big cable. And the brain is a myriad of connections, one part of the brain to the other, to this, because what happens is the signals have to go into one area, and the brain figures out what that signal means, sends it to another area, so that area can determine what that means, and it integrates all the information together so that you can come out with some type of response. Meaning if you see something that you like, well, the other side of your brain says, well, I appreciate it. One side of your brain says, I can see it. The other one says, I appreciate what I'm seeing. Or there's danger. I got to turn around and run, things like that. So the brain is all kinds of a myriad of wires that tell us what to do, what not to do, tell us we have pain, give us all kinds of information, that what to do with that information once we have it.
All right. And is that, what you're describing, is that an injury to the frontal lobe, or is that something known as corpus callosum?
No, okay, there's the frontal lobe, that's one area. In this report, there were 3 areas of trauma. One was the corpus callosum, one was the hippocampal area, the other one was the frontal cortex. Okay, those are the 3 main areas of injury. So, now, with the hippocampus, that's a memory issue. If you want to explain what those mean, I can do that, if that's what you'd like.
Yes, please.
The hippocampus integrates all kinds of functions, one being memory. The corpus callosum connects one side of the brain to the other, because the brain uses information from all over. It takes that information, sends it to one part of the brain interprets it in a certain way, and then sends it to another area of the brain and interprets it in a different way, is in milliseconds. And then it might go back the other way to another part of the brain. And you need this connection called the corpus callosum connect one side of the brain to the other. If you were to cut it in half, you'd have two brains thinking separately, and we couldn't get anything done because we wouldn't know what to do, because there's nothing that tells us, there's nothing that tells us this is happening, this is what needs to be done. So, again, hippocampus, memory, among other things, and the corpus callosum, you have to have this to connect one side of the brain to the other so that we can function appropriately. And of course, you have the frontal lobe, and this is the area that you've probably all heard of frontal lobectomies, when you have someone who is a personality that's very somewhat dangerous, and they've gone in there and destroyed certain areas of the frontal cortex that kind of mellows them out, so they become rather docile. So basically, frontal cortex is your affect, how you respond to a given situation.
When you say frontal lobectomy, is that also sometimes known as a lobotomy?
Yes, frontal lobotomy.
All right, let's talk about the damage in specific in this case to Mr. Copenhaver's frontal lobe. Can you describe that?
Well, understand one thing, that the MRI shows us an anatomical lesion. It doesn't give us really a diagnosis. It just shows us anatomically what's going on. So we take that MRI and we have to connect it to but we have to examine the patient. All that's connected. We do the MRI, we examine the patient, we talk to the patient. So if you put everything together to come up with a diagnosis. So the MRI, I'll make it clear, the MRI itself is not a diagnosis. MRI just shows us where there's a lesion. But technically, the frontal lobe is responsible for your affect, how you respond to a given situation. It has to do with, for example, if you have a trauma to the frontal lobe, you could perhaps see something that's horrific and it wouldn't bother you. You couldn't respond to it. You don't respond to it. You get what we call disinhibition, whereby you cannot control your activities. In other words, you do something that even though it's bad in the long run, you don't think of it as being bad in the long run. You just do something without realizing or without appreciating or anticipating what's going to happen after this is done. It's like the guilt center of the brain. It's like if you get rid of it, you could blow up a city and wouldn't bother you. Typically, patients who've had this kind of lesion, frontal lobe, they're hypersexual, they eat a lot, they're very aggressive. They do something. The main thing is they do something, they don't know they're doing it. If it's wrong, they don't appreciate it as being wrong. They don't appreciate the consequences. They don't care about the consequences.
Okay. You said something there that I want to latch onto. You said if they're doing it, they're not aware that they're doing it. What does that mean?
No, they're aware of doing it, but they don't care. It doesn't bother them that it could be inappropriate.
Okay. I want to add some variables to that. If someone has frontal lobe damage and they are taking testosterone or anabolic steroids, what does that do in terms of the combination?
Well, what theoretically what could do is, well, first off, I'm sure everybody's familiar with what's called testosterone rage,
Roid rage?
roid rage. You take testosterone, and if you take it beyond what is appropriate, what a doctor feels is appropriate, you become rather aggressive, volatile. That's basically it. You become extremely aggressive and uncontrollable. You become hypersexual because you have those. Testosterone is a sex hormone. So you become hypersexual, you do things like more to an extent than you would normally, along that vein.
Having sex 3 times a day or needing sex 3 times a day?
Yes, I mean, theoretically, yes, that's correct.
Okay. Now, the confluence of the two, or the sort of 1+1, frontal lobe damage and testosterone use. How do they influence together? How do they influence behavior?
I'm not familiar with any specific article in literature, but if you were to, if you realize that a frontal lobe lesion does what I suggested that it does, or doesn't do. In other words, it doesn't protect you. You're not protected from feeling guilty or stopping you from doing something that you know is bad. You don't have that ability. Then the testosterone, you have that rage. You mix the two together, and it's kind of obvious what could happen. I'm not saying what did happen, I'm saying what could happen.
Right. I mean, I'm not telling you to testify about the actual events. I'm just asking for an expert opinion of how these interplay. I want to add a third variable to the frontal lobe damage, which is now frontal lobe damage, testosterone, and are you familiar with a drug called Lexapro?
Yes.
Okay. And what is Lexapro?
Serotonin reuptake inhibitor, what that means is it's an antidepressant. And we use it's like Prozac, Lexapro, there's Paxil, there's all kinds of drugs in that group or in that category. And we use those for depression and also anxiety, or a combination of depression and anxiety.
And so now taking the three together, frontal lobe damage, steroid use, specifically testosterone, and Lexapro, does that add more to the unpredictability and volatility of the behavior?
Well, hopefully it'll control the behavior, but unfortunately, with those medications, you just never know, because I'm sure you've seen on TV whereby they're trying to sell you a drug, but they list all the things that could go wrong, millions of things that could go wrong. It scares the heck out of you. So one of those, of course, is suicidality. In other words, some of these antidepressants can cause an increase in suicide or suicide attempts. So although it's designed, that drug is designed to help you, to help calm you down, to help you become less depressed, it could have sometimes the effect that it's not intended to have. So there is, it's kind of a question mark.
Okay, and is there sometimes an issue with Lexapro in terms of wrong dosages?
With any drug, that's correct, yes.
Let me skip that question. Adding a fourth variable, improper use of Adderall, meaning not for ADHD. So now we have frontal lobe damage, testosterone, Lexapro, and Adderall. What is Adderall?
It's basically speed. It's amphetamine. And
So if it's misused?
well, obviously you become, you think it's helping you, but it fools you to thinking it's helping you because you think you can think more clearly. You think you can rule the world. You have unlimited knowledge and capabilities.
Can train harder?
It can allow you to train a lot harder. Well, in this case, yes, it certainly could. A lot of times you use it when you're studying for exams. It does help under the right doses. Problem is when you use it in doses that are inappropriate, then you could have all kinds of side effects. It speeds up your heart. It could cause some type of mania, like a hyper response. It can do all kinds of nasty things. It can exaggerate the normal things you do.
Okay, and in confluence with the other, I keep saying confluence, but in conjunction with the other three factors, the Lexapro, the testosterone, and the head injury, that adds sort of more gasoline to the fire?
That's a nasty combination, yes.
Now I want you to add into your thought a fifth factor, which is a history of uncontrolled rage going back to childhood. what does that add to the situation?
Well, when you assess a patient, I'll say a given patient, when you got to take a history. History is probably 80% of the diagnosis, 90% of the diagnosis, a good history. And you take the patient history and then what are your symptoms? That gives you the diagnosis right there, 90% of the time. But when you do a good history, especially a psych history, you have to go back to the childhood. I'll remember Freud, when, this thing where you're fairly Freudian, I'm sure, the Oedipus complex, things like that. You have to go back to your childhood to see if you were abused, sexually, physically, father was an alcoholic, mother was a drug addict, This type of history is utilized in an effort to determine why or how a patient presents himself, how he does his day-to-day activities. Is he normal psych patient, abnormal psych patient? Does he do things inappropriately? His history is very significant, especially in the psych realm, where psychiatrists and psychologists rely on that history in an effort to explain or define a patient's presentation, how the patient does what they do, why a patient does what they do. So it's very important to go back to day one.
Okay, did we meet Monday night
Yes,
for several hours?
yes.
And did I talk to you in depth about Mr. Copenhaver's social history?
I recall that we did it. I don't recall exactly what it was, but I recall that we discussed it, yes.
Okay, I don't want you to list the factors, but from that, did you draw the opinion that he's had kind of lifelong rage?
Well, from that I determined that his childhood wasn't one that I would like to have experienced. And I suggested to you that
Objection as to relevance of this beyond the scope of the expertise.
Come on up, please. defendant's childhood, the jury will disregard that. Go ahead.
Okay, I think we're up to a fifth here of someone who is, would someone who is a fighter with fighting training play into your opinion of ability to control?
Yes.
To what extent?
There's a term when we talk about head injury cases, and that's called the second impact syndrome. What that means is if you are injured upstairs and you get better and you heal, and everything's fine, and that's fine. However, before the brain is allowed to heal itself, if it's re-injured, the brain then does not have the capacity to fully recover before it's re-injured, and that prolongs and in fact worsens the condition, the physiologic and anatomic condition of the brain. And your question was regarding training. Well, now we're talking about repetitive trauma. So this is now, I'm coining my own phrase here, this is no longer second impact syndrome, but this is 100,000 impact syndrome, whereby you are injured, re-injured, re-injured, the brain does not have a chance to heal. And so you're just compounding these problems, magnifying these problems, worsening the problems from an anatomical, meaning how it looks on the MRI, and physiological, meaning how the patient behaves.
And in terms of the MRI results, is secondary impact syndrome consistent with the trauma to the frontal lobe?
Well, I mean, it could be consistent with trauma to any part of the body. In this case, the frontal lobe, yes.
All right, and so if I'm understanding correctly, secondary impact syndrome is concussion on top of concussion on top of concussion.
Correct.
And what's the length of time it takes a concussion to heal?
When we're dealing, as rehab specialists, when we're dealing with neurologic injuries, such as, say, a stroke, we're asked how long till grandpa recovers from a stroke. We usually say, in a neurologic injury, whatever you're going to get back, 90% of that will be realized within the first 6 months. Again, it means whatever you're going to get back, not how you were before, but whatever you're going to get back will be realized in the first 6 months. The next 10% will be realized over the next 6 months. So 100% of what you're going to get back will be realized within a year. Again, I must emphasize, it's what you're going to get back, not you're going to be where you were before in a year. It's whatever you're going to get back.
Okay, your example was based on a stroke. Is it the same with concussion?
With any type of brain injury, yes. Neurologic injury, yes.
So what happens then when prior to a year going forward, you either don't allow it to heal or even receive a second concussion?
And all bets are off. That equation that no longer holds. That's assuming it's one insult, one event.
Okay, so then what you said about, 100% coming back in a year of what you're going to get back,
Right.
will that apply to someone with secondary impact syndrome, meaning concussion after concussion after concussion?
No.
All right, and even if there aren't additional concussions, is the fact that someone might train every day in a manner where they're exerting force potentially on their head, is that going to disallow someone from healing?
Yes.
And now, considering frontal lobe damage, testosterone, Lexapro, Adderall, secondary impact syndrome, and coupled with fighting training, and an extremely exciting or shocking event that causes a heat of passion. How does that add to your opinion, if at all?
Well, certainly any type of stimulus could set whatever you have. A stimulus would take whatever you have, whatever is wrong with you and however you behave, it'll take that, depending upon the magnitude of the stimulus, it'll take that condition and magnify it, amplify it.
Okay. So putting all of these things together, in a situation with the heat of passion, again, significant frontal lobe damage, testosterone, Lexapro, Adderall, fighting training with secondary impact syndrome, and then against the backdrop of a shocking event, would you expect someone to act reflexively or thoughtfully in that situation?
Well, in general, I would expect someone to react reflexively, meaning you do something, you don't even think about it, you just do it. You just reflex. Reflex is something you can't control. Like if I tap your knee, that's a reflex, you cannot control that. That's something that's going to happen. So I kind of relate that situation to like a reflex, where it's going to happen no matter what. Out of your control.
Judge, I am going to object outside this building.
Come on up.
Okay, in terms of what you said about reflexively, that's a general opinion, not necessarily specific to this case.
General.
All right, do the memory issues related to the hippocampus, to what extent do they play into this, if at all?
Well, again, memory is something we don't fully understand even in this modern day and age. So, there's certain areas of the brain that create what we know as memory, not just one section. There's all kinds of areas that work together. That's, again, where the corpus callosum comes into play. The brain is connected by various, it's like a switchboard, various connections that formulate what we know as memory. And hippocampus is just one of these areas that if it is injured in some way, then that can affect memory. And there's different types of memory. I mean, in other words, you see something happen and you respond to it. To be able to do that, we have to see it, the visual center, then it's transmitted to another area, then to a motor area whereby it creates movement. So if we see something and it scares us, we run away. But it takes all kinds of connections in the brain to do this. And that's why we're taught, for example, in a fire drill, to do something when there's something happens, because if you've done it before, then you'll do it. You won't have to think about it again. You just do it. But it takes different parts of the brain to be able to do that. One of those areas, the hippocampus. The other area is the corpus callosum, and so on.
Okay. And in terms of frontal lobe damage combined with steroid use or abuse, the other factors, would you expect all people to stay in a reflexive rage, or can they come in and out of that rage depending upon provocations or situations?
You mentioned all. It's not everybody. It's just nothing is ever 100% in medicine.
Okay.
So
presuming it's one of the people that you talked about earlier that acts reflexively, is it just one duration that it will always stop, or can it stop and start over short degrees of time?
Well, it can be repetitive, because one of the functions of the frontal lobe, if you damage the frontal lobe, we develop this thing called perseveration, where your body continues to do something even though you've done it, you don't have to do it anymore. If someone tells you to draw a circle, they draw a circle, they say, "Okay, now draw a square," well, they'll continue to draw a circle. So in other words, you perseverate, you focus on one thing, you can't, so just one example, but the point is, you could react in a given way to a given situation for a second, a minute, an hour. You can wax and wane, it can go across the board.
In certain people with frontal lobe damage and testosterone use, can that cause animalistic type behavior?
Yes.
And likewise aggressive behavior?
Yes.
And when I say animalistic and aggressive, is that synonymous with reflexive?
Not necessarily, no.
Okay, can you explain that?
Well, animalistic, I mean, there's Lassie saved people's lives, so it depends on what you mean by animal. So, usually when we talk about animal, we usually mean that in an aggressive nature. So when you call someone an animal, that usually means they're mean, aggressive, and then we talk about reflex, means that's something whereby you can't control what you do. So animals don't do things reflexively all the time because they're able to think as well, think things out as well. But if they have a brain injury, just like us, they don't. The point is reflex, doing something reflexively is something you do without thought. You can't control it. And there's a certain area of your brain that control your reflexes. And the frontal area is one of those areas that controls your response to a given situation. It doesn't have to always be volatile, negative. It can be positive, but for the most part, it's negative, it's volatile, and it's like a mean animal, if that answers your question.
I have one last question. I know the prosecution's going to go over it, but do you know what you're being paid for your testimony today?
I really don't. I let my secretaries handle that. I just don't pay attention to that. I'm sorry.
Pass the witness, Your Honor.
Okay, Ross?
Thank you, Your Honor.
Good afternoon, Dr. Holper.
Good afternoon.
You know what, I thought you might not be able to tell us your prices, so just in case, I wrote them down. So in order for you to prepare for testimony, it's $1,200 an hour, is that right?
It doesn't sound right. I usually charge $200.
Okay. Can I approach with your
I think it's $200, but that, I get confused because they go all over the board. I don't know. I really don't know.
Do you want me to approach with your curriculum vitae and your
Sure.
fee schedule?
We got a fee schedule. My secretary sent out a fee schedule that I haven't looked at in I don't know how long.
Okay, do you want me to show it to you or will you take my representations? I can do it either way.
I trust you.
Okay, thank you. So it says that your testimony preparation takes, it's $1,200 an hour, and that your trial testimony is $3,000 for every half day that you're here, and that your fee for looking through medical records is between $600 to $2,500.
For what?
For medical record review.
But I mean, is that per hour, per day, or I don't know.
I don't know, these are your documents, not mine. And then, I didn't know what this was. It said IME, and that was $1,600 plus, but I didn't know what IME was.
Independent medical examination.
Okay, all right. So in regards to your preparation for testimony, how many hours did it take you to prepare?
First off, I don't like those charges. It's too much, to tell you the truth. It's
They're
just
your
too much.
charges, sir.
I let the girls in the office do it. I don't like those charges. I really don't. That's too much. But anyways, it really is. I'm under oath. It's too much. But
Okay.
anyways, look, I think the best way to do this, I agree with $200 an hour. That's what I think I should get paid to review documents. $200 an hour. Okay? Now, if I have to go to court, don't forget I have to schedule my patients out, this and that. But that $2,000 or $3,000, that's probably for a half a day.
Yeah, that's what I said, $3,000
right?
for half day.
But even that's a lot of money. But anyways,
Wait, sir, hold on, because you're going a little quick.
I'm
So
sorry.
this is the charges that you are charging the defendant. So I know you're saying that seems like a lot of money.
It's too much. I would never charge that. I'm telling you straight up, I won't charge that.
Sir, it's your fee schedule with your name, address, and business.
But I won't charge that. I'm gonna tell you straight up. I gotta look at that fee schedule again. I'm gonna tell the girls at the office, charge them $200 an hour to review the data, coming here, $200 or $300 for the hour. That's all.
So from today on, you're going to change your fee schedule?
That's too much. Yes, I'm going to.
So today when you get back to the office, you're going to tell the girls that they've got to change this?
Yes.
Okay. And so next time...
I didn't make it up.
Next time when I see you and I have a fee schedule, it's not going to look like this.
I'll tell you what I'll do. I will fax to give me your fax number. I will fax you a new copy of my billing, whatever you want to call it, by the end of the day.
I'm going to
How's
take you up
that?
on
No, give me till tomorrow.
it. Okay. Okay, so...
Honest to God, I'll do it.
Okay. So I guess what I'm trying to get here is this agreement has already been, you've already given these fee, and you were here for a day, half day yesterday. So were we billed $3,000 for today?
I was here half day. I'm sorry, I interrupted you, I'm sorry.
That's okay.
I was here at 1:30. I was supposed to be here from 1:30 to 2:30. That's what we agreed on.
Right.
So I probably was going to charge, that's not a half a day, that's just an hour, so.
Excuse me, what I understood to be the half a day is when a doctor comes here, they have to clear their afternoon full of patients. And so though they're not going to be here half the day, they have to charge for the half the day because they won't be seeing any patients. That's the reason for the $3,000 a day, right?
That's if I'm physically here from 8 in the morning till 12 in the afternoon, and it usually means if I have to travel. But I'll tell you what I do. We have a schedule, but I always work things out afterward.
Yeah.
I don't like to charge that kind of money, I really
guess
don't.
what I'm confused about is because Mr. Lederman just asked you how much they're being charged, and your response was, I don't know, the girls take care of it. So you don't really have
Right.
anything to do with anybody getting paid. The girls do it, right?
That's correct.
Okay. So,
I just don't like those charges, I'm straight up, I don't.
All right, let's move on.
Okay. So you have no idea how much you have charged the defense?
No, I don't.
Okay. Now, in regards to the report that you looked at, the report from Simon Med, explain to the ladies and gentlemen of the jury, you don't do the MRI, you don't do the scans, correct?
I do not physically perform the scans, nor do I interpret the scans.
So, someone else does, like a tech, does the MRI, correct?
Yes.
And then a radiologist interprets the scans.
That's correct.
And then what's your role in the process?
My role simply is, if you go to your doctor and you do some labs, he sits down with you and he goes over the labs. He didn't draw your blood, he didn't do the study itself, but he looks at the labs and then he tells you, his patient, what these labs mean, right? So my role is to sit down with my patient and go over with them the results and then explain the results if they don't understand what the results are.
Okay. So when you did this, did you look at the scans yourself, or did you just rely on Dr. Orison, the radiologist?
I relied on the radiologist.
Okay, so you didn't see the scans at all?
I did not.
Okay, so if I showed you a picture of the defendant's brain, you wouldn't even know that it's his brain.
That's correct.
So you're just relying on what Dr. Orison says in his radiology report?
I defer to his expertise.
Okay. Now, Dr. Orison, he's a well-known doctor amongst the legal community, correct?
I don't know.
Is it your understanding that he works with high-profile personal injury attorneys to diagnose brain damage?
I don't know.
You're not aware of that?
No.
Okay. Have you ever seen a report by Dr. Orison that didn't show brain injury?
To tell you the truth, I never, ever look at who interpreted it. I just look at the results. That's all I do.
Okay. So you looked at this, let's see, it's about a two-page report, but you never met with Mr. Copenhaver.
Never.
Any information that you got about Mr. Copenhaver came from his attorneys, correct?
Well, the information I got, some information, of course, was from reviewing the MRI, right? Which we've gone over. What else? It could have been, no, I'm pretty sure it was from the attorney, yes.
Okay, so anything that, all this information, like hypothetically about Adderall and Lexapro and all those things, you have never spoken to the defendant about any of these things?
That's why I made a point. My point is,
My
these
question
are
is
generalities.
yes or
I've
no.
never met with him. Everything I say is in general, doesn't
Right.
mean specifically him.
So the answer then is yes, you've never met with him, you received no information from him.
That's correct. Yes.
Now, I want to talk a little bit about, a little bit more of a foundation regarding traumatic brain injury. Normally, traumatic brain injury can be caused by what's referred to as an acceleration-deceleration type movement, correct?
That would be your typical whiplash injury in a car accident.
Well, that can be from like shaken baby.
I'm just giving you an example.
Right,
With
but
car
it can be
accident.
from a baby who's shaken,
Of
correct?
course, of course.
It could be from a boxer who gets hit,
Yes.
and that's the type of the brain accelerates and decelerates, which causes what's called diffuse axonal injury.
It can cause diffuse axonal injury, yes.
Now, I used the example of a baby being shaken. And sometimes if a baby is shaken too roughly, their brain, bumps back and forth in their skull, and then it causes an injury. And it's usually referred to as shaken baby syndrome, but some doctors don't like that term.
I hate the thought of that. I just want to think about it.
Okay. So I'll use that term as least as possibly can, but a lot of those children, even though sustaining an injury like that, can go on and live productive lives.
Well, it depends on the magnitude of the injury, yes.
And when we talk about the magnitude of the injury, we can usually see the magnitude of the injury on an MRI in regards to how much of the brain was affected by that. Is that correct?
Yes, it is.
And we usually refer to that as white matter on an MRI.
Yes, yes.
And the more white matter we see on the scan, the more, as a physician, you're worried about that child's or the patient's prognosis.
Yes, but that's the axonal we're talking about. That's the axonal
Diffuse
pathology we're
axonal
talking
injury.
about, yes.
Well, with any brain injury, though, the white matter is what would bother you, correct?
Well-
When you're looking at the MRI?
Any part of the brain would bother me. So, I mean, you can't just say white matter versus gray matter. We don't do that. We just,
Well, what does
It's
the
just
white
not
matter
done.
signify?
Objection, he didn't get a chance to finish his answer.
Okay, go ahead.
well, white matter is just the connections. That's all your connections. White matter is the exons.
Okay, and
Connections.
then-
It's myelin. Myelin creates that white matter. And then the gray matter is that's what we used to think, those are the nuclei in that. But for the most part, the white matter is what we use to connect, the brain uses white matter to connect one part to the other.
Okay, on the MRI, when we see an injury, what do we call that on the MRI?
Well, they'll specify. They'll say it's a nuclei or it's a white matter, but it's usually axonal. I mean, it depends on your radiologist and how you want to define it. But, it's okay to be white matter. That's fine.
Okay, and in this report, it's referred to as white matter, right?
Yes, it is.
Okay,
Yes.
so we'll call it white matter since that's what the radiologists
That's
call it.
fine. That's fine.
Now, I want to talk first about your opinions in regards to the hippocampus. That is in the center of the brain, right? The center lining.
Yes.
And that is not damage or an injury to that is usually not traumatic in nature.
Well, it's kind of deep, so it's somewhat protected, but it depends, again, on the magnitude. I don't know how to answer that question. I really don't, because it depends on what area of the brain is damaged and how the angle of the impact, the degree of the impact, so all different factors factor into what part of the brain is going to be damaged. So I don't know how to answer that question.
The hippocampus is the most protected part of the brain. Would you
But
say
I
that?
would say it's protected, yes.
Well, is it the most protected part?
You know what, if that's what it says in literature, I would agree with you. I can't say for sure. I don't recall.
But sir, you're the doctor of brains.
No, I'm not I'm not a neurosurgeon. I deal with, I'm trained in head injuries.
Okay, well, will you take my word for it that in the literature it discusses that the hippocampus is the most protected?
I already said I would.
Okay, thank you. And it would be very rare to see an injury to the hippocampus without seeing any other injury to other parts of the brain.
I would expect that if there were hippocampal lesions, that certainly would be other lesions in the brain, yes.
Now, in regards to the defendant's brain and the findings, there was no associated injury in or around the hippocampus.
I thought the hippocampus, they mentioned the hippocampus as being traumatized.
No, it says findings consistent with mild bilateral hippocampal atrophy, more severe on the left, and then the graph that the doctor showed both sides were within normal limits.
Okay, if they were atrophic then, that means that what caused them to be atrophic? Atrophic means it shrinks, okay? And it could be due to remote injury that usually trauma causes atrophy. So if the hippocampal area is traumatized, it will cause atrophy in the long run. It's not an overnight thing. It happens over months and years, the atrophy. But that implies that the hippocampus was traumatized, likely due to his area of his vocational endeavors.
So would you expect to see white matter on the MRI near the hippocampus then?
Well, if it's a remote lesion, if it's atrophy, maybe not.
Okay. And like I'm saying, while it does show atrophy, did you see the graph where it says that his hippocampus is within normal range?
What? Could you read exactly what it says, please?
Oh, I read, so I'm asking you, did you see the graphs associated with this report?
I'm not aware there were any graphs associated with that report.
Yeah, there were a few graphs associated with the hippocampus where they were ranging the atrophy, and they showed the defendant's hippocampus to be within normal limits. That's what I'm saying.
In
You didn't
terms of
see
its
those graphs?
size, or what? Dimensions, or what?
Yes.
The size?
Mhm.
Well, then why would they say atrophy? It doesn't make sense.
That's my question for you, because it was within normal limits. Normal
That's a
range.
contradiction, because if they say atrophic, that means it shrunk.
I know, I agree.
So,
But you didn't see the graph where it said normal?
I did not see that.
Okay. And so now I want to talk to you about and one more thing. When you usually have injury to the hippocampus, usually that person suffers from seizures. It can cause seizures, is that correct?
It can, yes.
And there was no history of seizures with this defendant in anything
No.
that you reviewed?
Not to my knowledge.
Now, what I'd like to do, just so the jury has an idea of the things that we are talking about.
No objection.
Thank you. Judge, I'm going to move to put into evidence states 8 through 281.
And there's no objection?
Correct.
You're admitted.
So, Doctor, right in front of you, there is a screen that you can actually work with. So I'm going to show you states 279. Can you explain to the ladies and gentlemen what we're looking at?
Like a brain.
Okay, and can you explain to them where the findings are of injury to the brain?
I can't interpret, I'm not good enough to interpret brain trauma.
Okay.
It's not what I do.
Okay, well, you know that the areas of white, the white matter, are injuries to the brain, correct?
The white matter, those white, they usually indicate a lesion. It's usually an infarct. You know, infarct meaning like a stroke or something. An infarct. It's an abnormal area.
Okay, well, I should say that these are all scans of diffuse axonal injury, if that helps at all. And so these white marks, so the jury knows when they're looking at a scan, these show what are referred to as lesions. And I think you used that when you were talking with Mr. Lieberman, is that correct?
Could, yes, yes, certainly, yes.
Okay. And then I'll show you another one, which is states 281. Now here we see several lesions and injuries of traumatic brain injury, and they're much bigger and vast in size, correct?
That's nasty, yes.
Yeah, that's nasty. So like, maybe, this is someone who either had a horrific injury or reoccurring
Or a multiplicity thereof, yes.
Now I'm going to show you 278. And I'm going to show you, do you see a lesion here?
No, I don't.
Okay, let me zoom in for you. See this?
Maybe right.
Let me just get out. Hold on, it takes a second to autofocus, sorry.
Maybe brightness?
There we go. Just
Right.
one.
There, I think.
Yeah, it'll focus in 1 second. Now you see it?
Yes.
See that little, like,
Yeah, I do. I see it, yes.
little tiny thing right
Yes,
there?
yes.
Okay. This is the defendant's brain.
Well, it's not the whole brain, that's just one slice through the brain. I mean, you could get a
Right.
myriad of slices, so that's just one thin
Right.
slice of the brain.
This is what the radiologist sent, showing the damage to the defendant's brain, or showing the lesion.
Okay.
Okay? So,
And sorry, so 281?
278, I apologize.
And the prior one you
The
showed?
priors are 280, the two I showed were 281 and 279, which are just examples of traumatic brain injury.
Okay.
278 is actually the defendant's.
Okay.
So, that lesion, should I use the term lesion? Is that okay to use with you?
Sure.
You had never seen it before.
Correct.
And so, when you were talking about, someone who's not able to make decisions or, act reflexively, are you saying someone with that, the size of that lesion would be behaving that way? Or are you just talking people with traumatic brain injury?
Well, first off, again, for the record, I'm talking in generalities.
Okay.
I'm not talking about a specific individual. I'm just talking about in general. And as far as this, what you've just demonstrated, it's like if you did labs on a patient and you just showed me the blood glucose level, but you didn't show me all the other 40 or 50 potential things you could test for on a lab. You just shown me one little area of the brain. You haven't shown me the whole lab. You haven't shown me the whole brain.
Okay.
Just a small area, which is of no value to me.
Okay, well, it's measured, and you read the report, and the measurement, did you read the measurement in regards to the records? I think it was less than, the white matter measuring 2 millimeters in maximum dimension.
What was 2 millimeters?
May I ask counsel where?
Yeah, sure, first page, 1, 2, 3, 4, 5th paragraph down.
This is the radiologist report?
Yes.
I don't have it in front of me, so
Do you remember reading it?
no.
Okay. It just says that it's approximately 2 millimeters in maximum dimension.
In what area of the brain?
There is a focus of abnormal increased flare and T2 signal involving the left superior frontal subcortical white matter.
Okay, I remember now, yes.
Okay. So there can be people all over the world walking around with an injury like that behaving completely normally.
I'm sure there are.
The defendant could have gotten something as simple as that from a fall off of a bike as a concussion as a child.
Possible.
He could have gotten it from playing soccer or Little League with a head injury as a child.
Possible.
He could have gotten it maybe, playing football as a little kid.
Yes.
There's no way we can age that.
Well, did it say, sometimes they'll reference acute versus chronic. If there's edema, that means it's usually acute. So I don't remember the exact phraseology.
It's not acute.
Okay, well, if it's chronic, that's fine. It could be chronic, could be from 10 years ago, 20 years ago. The important thing is, the MRI shows you certain information, but not all of the information. In other words, there's a lot there that could be there that the MRI does not pick up.
Like what?
There could be areas of microtrauma that the resolution of the MRI does not pick up. The resolution is only so good.
Is there any indications that the radiologist missed that in this report?
No, I'm not saying he did. What I'm trying to explain to you is, and the jury is that, and Your Honor, what I'm trying to explain is that what he sees is what he reports. I'm trying to explain to you is the MRI has a resolution, meaning how fine it can see, of only a certain degree. And then there could be a lot more there that we cannot see unless we dissect his brain and look at it under a microscope.
Well, sir,
There are limits.
you know that we can't do that.
That's my point. In other words, you
So
can
we
only work with
can't-
what you have,
Right.
and you have to connect this, what you see, with his physical symptoms. I think in the very beginning, I mentioned that history is 80% of the diagnosis,
Okay.
right? Remember I said that?
Sir, there's no
80%.
question before you right now.
I'm going to object, he wasn't finished answering the last
Well,
question.
In states 281, when we're looking at this type of brain, it doesn't look like the radiologist is missing much in regards to this brain. We can clearly see the types of injuries and how big they are on this brain, correct?
Well, we can, but we have to connect this with a history. I can see this, but I have to know the history. What happened?
You need to know the history to know that this brain is injured? Look at those lesions.
I want,
The question is, do you need to know the history to know that this brain is injured?
those could be metastatic lesions. Those could be cancer.
Sir, yes or no?
It's not,
I'm
objection.
trying to explain to you that they don't have to be from trauma. They could be cancer. It could be all kinds of different
And I have
things.
told you that these are scans and MRIs from traumatic brain injuries, okay? So looking at that brain, does this person suffer from traumatic brain injury?
I can't tell you.
You can't tell me that looking at all of these lesions.
Because you have to connect the patient's symptoms, when you examine them, you have to talk to them, you examine them to tell for certain.
Showing 278. But you can tell me in 278 that this is a traumatic brain injury?
No, I can't, because the radiologist has to tell me that. I'm not a radiologist.
But you interpret radiologist findings.
The radiologist interprets what he sees. Then when he gives me a report, then I understand what the problem is. Right? For example, with a history of trauma, then I understand it. But if you tell me there's no history of trauma, then I say, well, wait a minute, there's something we're missing. What else is there? The point is you have to talk to the patient. You have to examine the patient. You can't, I tried to tell you right from the beginning, it's a matter of diagnosis, but it's not even a diagnosis. It's just something we have that shows us what it possibly could be. We have to connect this with that, with this, with that.
Sure,
It's
great.
just part of it.
And the most important part is seeing the patient, treating the patient, getting the history of the patient,
Of course, that's what I've been trying to explain to you from the start. Yes,
which you didn't do in this case.
exactly. That's why I'm speaking in generalities when I'm giving my responses, in generalities.
So would you expect someone with the lesion that I showed you that the defendant has in 278, would you expect that person to be able to run their own business?
I can't tell you. I have to examine the patient and talk to the patient. I'd have a neuropsych eval done. If it's a forensic situation, I'd send him to a neuropsychologist, get a complete neuropsych eval.
Then how are you able to say that someone who's on Adderall and Lexapro and has a diffuse traumatic brain injury, that they're going to be like an animal?
In generalities, I'm speaking, and yes, because that's a bad combination. And in my experience, my training teaches me that this is not a good thing to have. That could lead to this type of behavior.
So, but I mean, you're saying could. Anything is possible, right?
Exactly.
So I could give you any drugs or any type of factors and you could say it's possible.
Depending on what you're giving the patient.
Okay, so you're not able to tell me, even with the history that you have, and you've seen the imaging, whether or not the defendant would have been able to run a successful business. You can't tell me that.
You're correct, I could not.
You can't tell me whether or not he would be able to manipulate others.
I could not, you could not, right?
Could you tell me whether or not he'd be able to drive a car?
Unless, I mean, if that's all the information I have, I couldn't tell you, no.
Okay, so you are just here to say that some people who have traumatic brain injury are not able to control their impulses.
Yes, I'm trying to suggest to you that given this set of circumstances, this is what could happen.
Okay.
That's all I'm saying.
And now that you've seen the report and you've seen the scan of the defendant's brain, you have no ability or any opinion to say what he could and couldn't do.
Of course, because I have not examined him, nor has there been a neuropsych eval done on him.
Now, in 278, the image I keep showing you of the defendant's brain, like I was stating, there are people walking all over the world with something like that in their head, and they don't even know it's there.
Probably.
Like I said, I fell off my bike when I was little on the concrete, and I had a concussion. But I could be walking around with that, and I don't even know it.
Correct.
And I could still be able to control my impulses.
Correct.
Recently with the movie Concussion, have you seen that movie?
No.
It's based on a doctor by the name of Dr. Bennett Amalo, who works outside of Chicago, who studied traumatic brain injuries, and he's the one who kind of worked with the NFL and talking about.
I'm aware of it, yes. In fact, I heard on the radio, public radio, I heard they discussed with him his background and how he came up. So I'm familiar with the movie, yes.
Okay, perfect. And so there have been several hundreds of football players and some boxers who have been studied to show, if they have lesions and their actions. Are you aware of that?
Most certainly, yes.
And in almost all of those cases, they are not violent, acting like animals, have any of those impulse control issues.
I don't know the statistics. I don't know. I'm sure there are, but I don't know the statistics. I really don't.
I mean, if this were an issue, then if this were a true issue with people who had concussions, the world would be a lot more violent place if we were falling off our bikes as kids and then running around killing each other.
I'm going to object. This is far beyond the scope and beyond his ability, beyond his expertise.
Overruled.
I mean, I don't even know how to answer that question. I mean, all I can tell you is I'm trying to explain to the court what these lesions and what these findings could cause in a given individual. That's all I'm suggesting. What theoretically could be based on my experience, my knowledge and training. That's all I'm telling you.
And so you said they could act like an animal.
They could act like a saint. You don't know. You have to talk to the patient, examine the patient, send them out for a neuropsych eval.
But the more evident the white matter is in the brain, the greater your concern is, correct?
I'm sorry? The more what?
The more evident, like in States 281, that the white matter is in the brain, the greater your concern.
Oh, wait, okay. You're confusing. There's white matter and there's gray matter. Those are things that the brain has to have, okay? I think you confused me earlier with your terminology. Because when you say white matter, you're confusing white matter with an infarct. Infarcts can cause white-looking lesions, yes, but that's not called white matter.
Okay, let me just use it from the report that you relied on, okay? Signal involving the left superior frontal subcortical white matter.
Right, that's normally what you find in the brain. That's an area anatomically of the brain, the subcortical white matter. That's a normal area part of the brain. That's all it is. It's telling you where it is. White matter as opposed to gray matter.
So you're saying that when they're saying white matter, they're not referring to this?
They're not referring to trauma. No, that's why you confused the heck out of me before.
They say white matter measuring approximately 2 millimeters. So maybe the radiologist is confused.
No, trying to explain to you that there's gray matter and white matter. It looks, the white lesions, you sure didn't say white lesion, the lesion.
Can I approach, Judge?
Yeah, it'd be nice if I had that.
Yeah, that'd be good. Let's go ahead and read
Now,
that and let me know.
Where is that?
I
Show me.
underlined it for you.
Okay, all right. Focus of abnormal increased flare, T2 signal involving the left superior frontal subcortical. Okay, involving the left, okay. There's a focus of abnormal increased flare and T2 signal involving the left superior frontal subcortical white matter. Now, this is an area, okay, of the brain. It's telling you that there's a flare in this area. It's not saying that white matter is abnormal. White matter is a normal part of your brain. It's telling you where the flare lesion is. It is in the left superior frontal subcortical white matter. It's in the white matter. The lesion measures 2 millimeters, but they're not talking about the white matter measuring 2 millimeters. The white matter is also your brain, okay? It's the flare lesion that measures 2 millimeters. That's why you need to understand your terminology before you start trying to crucify me. You don't understand terminology. Now I'm trying to explain terminology to you.
Excuse me, he's not done with his answer.
Well, he should be done.
He answered the question.
Okay, well then here, I'll use your terminology.
It's
about
everybody's
these
terminology.
lesions. About these lesions. You want to use the term lesion for these?
That's what I said from the beginning.
Great, so let's use it. 281, do you see the lesions? It's on the monitor in front of you.
These are all lesions. They are not white matter
We got
as
that
you
clear
believe.
now. Thank
Do
you.
you
Okay.
see the lesions? Sir, do you
I already said I did, yes.
you see the lesions?
I do.
Okay, so now in 278, I'll zoom in. Do you see that lesion?
Not the way you're showing it. I don't see anything there. On my screen, I can't see it.
I'll point it out with my pen for you.
Mike, I can't see it on my screen. Wait a minute. There may be, yeah, right
Yes.
there, yes,
Okay.
I see it.
My question to you is, when looking at these and when reading these, the more lesions that you see, let me zoom out for you, the more lesions that you see, the greater your concern would be.
Yes.
Nothing further.
Redirect?
Yes, please. Did counsel for the state accurately depict how severe you would judge a brain injury?
Absolutely not.
Not even close?
She didn't come up with the, she doesn't know what a white lesion is.
Come on up. Go on.
Okay. When I asked your initial opinion in this case, was it based solely upon the brain scan and the MRI results?
I based my opinions on what I reviewed referencing the MRI study and the information that was given to me by yourself
Okay.
regarding your client.
Okay, and these are generalities and hypotheticals, correct?
That is correct.
And for generalities and hypotheticals, you don't have to meet with a patient and assess them in person, correct?
That's correct.
All right, so when I asked you in relation to the MRI findings, did I also ask you to factor in steroid use, Adderall use, Lexapro, mixed martial arts and Brazilian jiu-jitsu training, and a shocking, startling, or heat of passion causing event?
Yes.
And does all of that form a richer tapestry than solely an MRI result?
It does.
And is that why your opinion was that under these circumstances, the behavior might reflect reflexes or animal-like behavior?
In general, theoretically, yes.
Nothing further.
You cross again?
Hold on, George.
Okay. Hang on just a second, sir. Counsel, come on up, please. Right, doctor. Can someone have brain injury or a concussion and there not be lesions or some apparent mark on the scans?
You can have brain injury, a traumatized brain, without there being abnormalities noted by MRI criteria.
Do MRIs always show the extent of injuries or show injury at all?
Not always.
Is it true you have to biopsy someone's brain to know the true extent of injury?
Well, we try to avoid biopsying brain, but that's not true. Biopsy has nothing to do unless you have a metastat or some type of lesion that you can't determine what it is by any other means. But, you know, biopsying a brain is a very dangerous procedure. It's something we try to avoid. But can you, in this case, or a case of head injury, you never, ever biopsy the brain. You just don't do it. Again, as I tried to say, we look at the MRI, we look at other findings like the neuropsych eval, if you have one, and sitting down, talking to the patient, examining the patient.
Thank you, sir. Any follow-up on that?
There isn't.
Steve?
Yes. What are the differences in doing an MRI without contrast and with contrast?
Well, there's different reasons we do with contrast. For example, if looking for bleeds, that's usually the reason, a bleed, or say a metastatic lesion, cancer, something like that.
Now, did you say this was done, this one was done with contrast and without contrast?
I'm going to object, this is beyond the scope of the
No,
questions.
I'm building the foundation to answer one of the questions.
When I,
Okay, so
I'm sorry.
go ahead.
When I was sitting here and the question was presented to me, I honestly couldn't remember if I ordered it with or without contrast. I couldn't remember. So I suggested that, well, okay, pretty sure it's with contrast, but I'm thinking to myself, why would I have ordered it with contrast? I don't know why I would have ordered it with contrast, because there's no question.
So what did you
So I
do,
don't,
sir?
I suggested that, but my memories told me with or without, but now I'm second guessing myself. I don't recall if I did it with contrast. I just don't recall.
Okay. I remember when Mr. Liederman was asking you questions, you said that it was done with contrast, but,
Per my recollection.
okay. The scans that were ordered were actually without contrast.
That's why I was thinking, am I saying the right thing? Because I didn't want to get myself into trouble.
Okay, so they're
Okay.
without contrast?
I screwed up, I'm
That's,
sorry.
no, that's okay. So I just wanted to, is one of the ways you can tell if the person is suffering from like an acute injury, is there a way you can tell by maybe either, how does it work? If you inject a dye in, is that how it works?
Right, yes, and then you can see if there's well, you can see something that shows up as a lesion, as a bleed that you can't see without doing the contrast. But there's different things we inject, depending on what you're looking for.
So let's say you do a scan on, in January, and you see that there's a lesion. Then can you do another rescan in July to see if that has changed at all, or if there are more lesions, etc.?
Depends on what you're doing the contrast study for, but if it's a bleed, it'll be gone.
And what if it's, lesions like we're talking about here?
So yeah, that's what I'm saying. I don't know why you wouldn't need a contrast. That's why I was second guessing myself. You really don't need a contrast study.
So how would we know if someone was being acutely affected by a lesion?
We have to talk to them, examine them. That's the only way. Take a history. It's 80%, as I told you, that's 80-90% of the diagnosis. Take a history, examine the patient. Unfortunately, I didn't have that ability.
Okay. So there would be no way to, like I was saying earlier, there's no way to age a lesion. So someone could be living with this their entire life.
Unless you see the edema, as I explained earlier, edema means just swelling,
Right.
okay? And that's usually a very short-lived situation, right? So you really can't, you really can't age it.
Okay. One second. One second, I'm looking for something in my records. Now, with someone who, this was the only report of the brain that you were given, correct? These are the only findings that you were ever given?
Yes.
So, to your knowledge, when you were given history by defense, bless you, so you were given the history by defense, there had never been any imaging beforehand.
That I was aware of, no.
So the first time this came to be a concern was in the middle of a trial.
I'm going to object, we'll all be on the scope.
Is it, sorry, come on up a second.
you, Dr.
Okay, thank you.
Any further questions for the defense?
Yes.
Sorry, not quite yet, Doctor.
Okay.
Okay, you said you just told counsel you reviewed records from Simon Medical.
That's the MRI.
That's the MRI. And do you have any reason to believe that the doctor who read and interpreted these results, the radiologist who read and interpreted these results, made mistakes or, embroidered their testimony or embroidered their results to be inaccurate on this to help the defendant?
No, there's no way it could happen.
And based upon what you read, did you find the brain injury to the frontal lobe to be significant enough that when combined with the other factors, someone in that situation would tend to act reflexively and not...
Objection asked and answered and beyond the scope.
No, it's... Come on.
Come on up. Overruled, go ahead.
All right. The last question was, based upon the findings as you read them from the radiologist, plus the other factors I had identified, the testosterone, the Adderall, etc., the fighting, the exciting event, is that what the totality, is that what you've based your opinion on, that these actions would tend to be reflexive and not considered?
In general, theoretically, yes.
Thank you. Nothing further.
Anything further for the state? Thank you, Doctor.
Thank you.
Okay. Appreciate your time. Sorry, counsel, one more time. Can you come up for just a sec?
Sure.
All right, next witness?
Chad Collins, please.
Follow me. Do me a favor, make your way up from the box, remain standing. Raise your right hand, face that gentleman right there for me.
You solemnly swear that the testimony you're about to give this action be the truth, the whole truth, and nothing but the true self, God?
I did.
Thank you. You may be seated. You state your complete name, spelling both your first and last name for the record.
Chad Collins, C-H-A-D-C-O-L-L-I-N-S.
Go ahead, counsel.
Thank you. Mr. Collins, do you know an individual named Christine McInday who goes by the trade name Christy Mac?
You know I do, or I wouldn't be here.
Okay, he's got to ask questions in court because the jurors don't know what
Gotcha.
it is, okay? All right, go ahead.
Yes. Do you know a person named Erin McInday?
Yes?
Did you date her?
Yes?
Did you live in a house with Christine McInday and Aaron McInday at some point?
Yes.
When was that?
Approximately 2 years ago. I moved out the day before the incident we're all here for happened. I lived there a year before that.
All right, so maybe about August 2013 to August 2014?
Roughly, yes.
All right. And in that time, are you familiar with Mr. Copenhagen?
I am.
All right. In that time, did Mr. Copenhagen live in the house? Sometimes.
At
not
times,
all.
sometimes, yeah.
Okay. You recall hearing, not asking about, well, you weren't present on August 8th, correct? You said you moved out the day before?
Correct.
All right, so you weren't in the house?
No, sir.
Okay, during the times that Mr. Copenhagen lived there, did you witness fights between Ms. McInday and Mr. Copenhagen?
I did not.
Did you hear or see anything during the time you lived at the house that would constitute domestic violence?
Hear or see anything
Correct.
as far as them fighting?
Physically?
No.
Loud arguing?
No.
Do you ever see Ms. McInday with cuts, bruises, black eyes, things like that?
Not until after August the
8th. You're aware, by Ms. McInday, by the way, I mean Christine. Christine. Are you aware, do you remember what her birthday was?
No.
May 9th sound about right?
Yeah, I couldn't even tell you.
Okay. Do you recall a time when you went to Benihana's?
I do.
Okay.
Yep.
And that was with Mr. Copenhagen and at least Christine McInday?
Yes.
Okay, what do you do for a living, sir?
I'm an entertainer.
Okay. What type of entertainment?
I do everything from play live and also run a wedding business.
Okay. All right, I have nothing further.
Ross?
Good afternoon, sir.
Hello.
When you stated that you were living with both Mom McInday and daughter McInday, how long was that period for? I'm sorry, I didn't hear.
I would say it was approximately about a year or just under.
Okay.
Yeah.
And during that year time period approximately, how many times would you say you were around the defendant and Christine McInday together?
Half a dozen, maybe.
Okay. When you were around them, was it for long periods of time or was it just coming and going?
It was either coming and going. I mean, like I said, we went out for her birthday dinner. You know, they were always kind of doing their own thing. They were either homebodies or unless she had a special event to go to, they pretty much stayed around the house.
Okay. Now, during that time period, you also were working at a local chapel. That was owned by you.
Correct.
Did you work a lot or would you
I was
go?
always gone. I was pretty much only home to sleep.
Okay. And so I guess my question is did you feel like you knew the ins and outs of their relationship at all?
Not really, no.
And your relationship with Miss Erin McInday, and I don't want to get into what anybody said, but were you aware of whether or not she had some serious concerns about her daughter's relationship?
I was aware that she had some concerns about the relationship, and that's pretty much about the extent of my knowledge about anything involving this case.
Okay. Thank you so much.